In this lecture, we will discuss conduction defects caused by anterior wall infarctions along with their clinical significance. As we mentioned in a previous lecture, the conduction defects caused by anterior wall MIs are often permanent because of necrosis, which is a reversible cause. They are due to left anterior descending artery or LAD occlusion, which supplies the anterior portion of the left ventricle, and it causes infarction of the interventricular septum. Now, AV blocks tend to result from necrosis of the His bundle and is the reason why any escape rhythm typically has a wide QRS complex origin or rhythm, and it usually has a right bundle branch block patterned. A prolonged PR interval is also not uncommon with these anterior wall MIs. Now, if second degree AV block is present, it is often Mobitz type 2, and this is more common than we saw in the inferior wall MIs. If extensive septal necrosis is present, third degree or complete heart block can develop and is often preceded by a new right bundle branch block with a left or right axis deviation. Now, one thing to be aware of is that the right bundle branch block pattern secondary to septal infarction is often associated with a Q wave in lead V1. That is a QR complex and not the typical RSR prime complexes that we'll see in right bundle branch block. So if you recall, with right bundle branch block, we had that RSR prime, okay? Sometimes they'll go dip deep, okay? And that's our RSR prime and our right precordial leads. But in this case, if there's an infarction, we'll actually get those pathological Q waves that develop, okay? And this first R will not be there. So instead, you'll have a complex that may look like this, okay? Where you have a Q wave and your R wave, and we call those QR complexes, and that would be in those right precordial leads, okay, in the setting of an MI. Now, if you recall, it's not uncommon to have right bundle branch block associated with a left anterior fascicular block because both the right bundle branch and the left anterior fascicle are supplied by the proximal septals branches of the LAD. Therefore, if you obstruct the LAD, as in with this anterior MI, it makes sense why you would see this bifascicular block appear. Now, as you may already know, the combination of right bundle branch block with left posterior fascicular block is not nearly as common. Okay, so if we have our LAD here, we have occlusion there, and again, we're saying that both the right bundle branch and the left anterior fascicle are supplied by the proximal septal branches of our LAD. Okay, here's our septal branches. Okay, here's our right bundle branch, and you can see as well as our left anterior fascicle, so right in this region here. So if that's if the anterior portion of the wall is affected, you can see how we can commonly see this bifascicular block occurring with the left anterior fascicle and the right bundle branch. So just a few last clinical points to make here. An important thing to be aware of is that the bifascicular block significantly increases the risk of a patient developing complete or third degree heart block, especially if there's simultaneous first degree AV block where there's a constantly prolonged PR interval. Okay, this would be referred to as a trifascicular block, and a pacemaker would likely be needed in this setting. In fact, third degree heart block associated with the anterior wall MIs has a very high mortality. All right, let's review what we discussed before we end here. So conduction defects in the setting of an anterior wall MI are often permanent. Okay, this was different from the inferior ones that tend to be more transient, resolving in within 1 week, and that's because there's necrosis. Okay, so this is an irreversible mechanism, and because of that, they tend to last and be permanent defects. Okay, it's caused by these left anterior descending artery occlusion. Here's our LAD. You can see an occlusion there, and because of that, we get interventricular septal necrosis, so right over our interventricular septum. Okay, we can get AV block secondary to His bundle necrosis, in which we can see these wide QRS complexes because it's originating below that bifurcation. So our His bundles is then damaged in this case, so it would occur down here, and we'd get wide complexes occurring in that case. We can also see an increase in the PR interval, so it's prolonged, like in first degree AV block. Second degree AV block, Mobitz type 2 is more common than the Mobitz type 1. Third degree AV block can also occur if there's extensive septal necrosis. And then we mentioned right bundle branch block can occur with third degree heart block with left or right axis deviation. Okay, and then we talked about those QR complexes instead of those RSR prime complexes that we tend to see with right bundle branch block because of those pathological Q waves that are appearing here. Remember, right bundle branch block can be associated with left anterior fascicular block because those are both being fed and they receive blood supply from those proximal septos off the LAD. Okay, and if you have this, it increases the risk of third degree AV block, especially if first degree AV block is present. Again, this has a high mortality in these patients. Well, that's the end of this lecture. We discussed conduction defects caused by anterior wall infarctions along with their clinical significance. I hope you learned something.